I'm Dr. Fred Baumann. I've been a neurologist and child neurologist for 35 years. Neurologists determine whether or not patients have diseases of the brain and nervous system. We encounter such things as multiple sclerosis, brain tumors, mental retardation, and developmental abnormalities. Like all physicians, neurologists encounter patients with symptoms but no objective abnormalities, having such things as depression, anxiety, panic attacks, and sleeplessness. By process of elimination, such things are concluded to be psychogenic, arising from the stresses of everyday life. Attention Deficit Hyperactivity Disorder, ADHD, was said to affect 150,000 children in 1970 and is said to affect 5 million today. Seeing such children in my practice and being unable to demonstrate a physical or a chemical abnormality, I have been unable to validate ADHD as a disease. A 1994 Time magazine headline asked, "Is it for real?" If your child were said to have cancer, diabetes, or epilepsy, surely you would want to see confirmatory test results such as biopsy results, a glucose tolerance test, or an electroencephalogram before starting your child on necessary but dangerous medications. Ritalin is the drug of choice for attention deficit hyperactivity disorder, and yet the Drug Enforcement Administration and the International Narcotics Control Board state that the addictive potential of Ritalin is very high. Furthermore, in over 3,000 reports of complications to the FDA between 1990 and 1997, there were 160 deaths and over 500 hospitalizations. Surely you would want validation that your child has an actual disease before putting them on such a dangerous addictive drug. In November 1998, the National Institutes of Health convened a consensus conference in Bethesda, Maryland, to clear up the controversy. Announcing the conference, Peter S. Jensen, Planning Committee co-chair of the National Institutes of Mental Health, acknowledged, quote, "ADHD has been surrounded by long-standing controversy. This controversy surrounds the actual diagnosis of ADHD, that is, whether the diagnosis simply pathologizes normal child behavior and whether it is a function of large classes, too busy parents, or the machinations of a medical pharmaceutical cabal," close quote. On May 6, 1998, I wrote to Jensen stating, quote, "A consensus conference will not suffice. A forthright confession that ADHD is not a disease, that the children are normal, is called for. Unless there is a frank and public statement that ADHD is not known to be a disease or anything abnormal within the child, the consensus conference will only be another element of the fraud." Let's briefly introduce the major participants in the consensus conference. The National Institutes of Health contains 15 component institutes. The National Institutes of Mental Health, on Drug Abuse, and Child Health and Human Development are co-sponsors of the consensus conference. The National Institute of Mental Health is the most important psychiatric institute in the world. Research on psychiatric drugs is directly funded by pharmaceutical corporations themselves. Interrelationships between the pharmaceutical industry, medical schools, and institutes of the NIH are pervasive. The other major player is Children and Adults with Attention Deficit Disorders, CHADD. CHADD, 600 chapters and 35,000 members strong, is comprised of parents who believe in ADHD and Ritalin for their children, themselves, and for the entire country, and of mental health professionals who make their living diagnosing and treating ADHD. Unknown to the public, Ciba-Geigy, manufacturer of Ritalin, has contributed over $1 million to Chad since 1990. Furthermore, the International Narcotics Control Board has expressed concern about Chad's lobbying for the use of Ritalin for ADHD. They state, quote, "Financial transfer from a pharmaceutical company with the purpose to promote sales of an internationally controlled substance would be identified as hidden advertisement in contradiction with the provisions of the 1971 Convention on Psychotropic Substances," close quote. Finally, regarding the American Psychiatric Association itself, psychiatrist Matthew P. Dumont has editorialized, quote, "The profession should give up its claims to psychotherapy and social science and openly declare its identity as an arm of the drug industry, period," close quote. It is my opinion that the concept of ADHD as a disease was invented to sell drugs. The Consensus Conference reveals much of the unscholastic role of the U.S. Department of Education in the production of the so-called ADHD epidemic. I will now take you by videotape to the Consensus Conference held November 16 through 18, 1998 in Bethesda, Maryland. You will see whether the state of the science is articulated or not, and you will see whether or not at the end of the conference the results are fully and forthrightly shared with the press and the public. This is Stephen E. Hyman, M.D., Director of the National Institute on Mental Health. The NIMH, a sponsor of the Consensus Conference, is the most important research institute in the world concerning ADHD, child, adolescent, and adult psychiatry.
This is, in some ways, an ideal topic for a Consensus Conference, in that there is a great deal of data to be sifted out, both for its consistency and for its quality, so that we might, hopefully by the end of this, have some agreement on a shared body of data from which to act. At the same time, when we look out in ordinary practice in the United States and indeed throughout the world, we see very troubling differences in the rates of diagnosis of attention deficit hyperactivity disorder, in the conceptualization of what it is, and in the approaches to treatment. While the drug methylphenidate or Ritalin should by no means be considered coterminous with attention deficit hyperactivity disorder, it has often been a marker for its diagnosis and treatment, and we know, for example, that the rate of prescription of Ritalin ranges from 0 to 3% in some school systems to well above 40% in other school systems. This cannot be right. And that is precisely the sort of circumstance for which one needs a Consensus Conference.
Frequency differences of from 0 to 3% in some school systems to 40% in others are troubling indeed. Surely we don't see such differences for diabetes, epilepsy, or leukemia. Asking us to consider whether ADHD is a disorder or a condition, Hyman retreats from the "is it a disease or isn't it" controversy and from the specific language demanded by medicine. Saying ADHD is not coterminous with Ritalin, Hyman denies the obvious. Once the label is applied, the Ritalin prescription is automatic. This is Alan I. Leshner, Ph.D., Director of the National Institute on Drug Abuse, another sponsor of the Consensus Conference.
We're here today on behalf of clarifying a situation for millions of young people who suffer from attention deficit hyperactivity disorder. I'll just second everything that Dr. Hyman said, and let me add that the reason, or a reason, that the National Institute on Drug Abuse is also involved in this activity is multifold. That is, it's bidirectional. On the one hand, having attention deficit disorder with all of the psychological consequences of suffering from that disorder is of itself a risk factor for drug abuse and addiction, and there's by now a substantial body of literature on comorbidity between ADHD and eventual drug abuse and addiction. And on the other hand, many of the medications most frequently used to deal with ADHD are in and of themselves abusable substances.
Leshner calls ADHD a risk factor for drug abuse and addiction, just as diabetes is a risk factor for vascular disease, neuritis, and blindness. Psychiatrists regularly resort to real disease analogizing, likening ADHD, depression, and anxiety, etc., to cancer, diabetes, and epilepsy, etc. In obtaining informed consent, the representation of ADHD as an actual disease when it is not is a violation of informed consent and is tantamount to medical malpractice. This is John H. Ferguson, M.D., Director of the NIH Office of Medical Applications of Research, the third sponsor of the Consensus Conference.
Each speaker has been asked to submit documentation to the ACCME outlining any real or potential financial conflicts of interest. We have not prompted the speakers to disclose real or potential financial conflicts publicly during these open sessions. However, in the spirit of applying such standards now required of members of NIH study sections and advisory councils, as well as contributors to scientific journals, and in noting the controversial topics such as today's, often discussed at these conferences, we feel that members of the panel or audience should inquire about such ties of the speakers should they deem it appropriate.
Although Dr. Ferguson has made much of the lack of conflict of interest of panel members and invited participants alike, published disclosures, if any, were not made available, and he has yet to answer my written request for such documents. It is pertinent, I think, that so many ADHD researchers have close ties or hold official positions with CHADD, children and adults with attention deficit disorders, several from the National Institute of Mental Health itself. Dr. Hyman was a keynote speaker at CHADD's 9th Annual International Conference. Although Planning Committee Chair Peter Jensen had acknowledged in an article in the spring 1998 Attention magazine that whether ADHD is a valid disease or not was the main controversy, only one of 30 invited speakers was specifically scheduled to address this question. William B. Carey, M.D., a professor of pediatrics at the University of Pennsylvania School of Medicine, presented, quote, "Is ADHD a valid disorder?" Close quote. Let me remind the viewer that the American Psychiatric Association and its Diagnostic and Statistical Manual use the term disorder to mean disease which implies a physical abnormality within the patient. Now to Dr. Carey.
ADHD is defined, as we've heard and as you know, of the 6 out of 9 inattention or 6 out of 9 of the hyperactivity impulsivity symptoms for 6 or more months. It's been present from before the age of 7 years with impairment in 2 or more settings, not due to other conditions. Additional common assumptions about ADHD include that it's clearly distinguishable from normal, constitutes a neurodevelopmental disability, is relatively uninfluenced by the environment, and can be adequately diagnosed by brief questionnaires. All of these assumptions, and some others, must be challenged because of the weakness of empirical support and the strength of contrary evidence. The 60 references supporting my position are listed in the 30-page full version of this paper.
Herein, Carey challenges basic assumptions about ADHD. One, that it is an abnormality within the patient distinguishable from troublesome behaviors in normals. Two, that it is a neurodevelopmental disorder, a brain disease. Three, that having a brain disease, the course of the patient is little influenced by environment. And four, that it can be reliably diagnosed by brief questionnaires.
The literature of ADHD defines the inattention and high activity behaviors as abnormal and easily differentiated from normal temperament variations using cut points in numbers of symptoms. But these same behaviors are also described as normal yet potentially aversive temperament risk factors, and many children who have them are free of dysfunction. Half of any population is more active than average, and half is less attentive than average. Temperament research informs us that dysfunction results neither from the numbers of risk factors present nor from extreme ratings of them, but when any number of them induces a poor fit with a particular environment. Children with difficult temperament, for example, the difficult temperament cluster of low adaptability, negative mood, and so on, are more likely to develop social behavior problems, but often they do not. Those with the low task orientation cluster, high activity, low persistence attention span, high distractibility, are more likely to do poorly in academic achievement, but often they do not. No solid data support the current cut points where normal high activity and inattentiveness leave off and abnormal amounts begin. The absence of clear evidence that ADHD symptoms are related to brain malfunction. The ADHD behaviors are assumed to be largely or entirely due to a neurodevelopmental disability. The DSM-IV doesn't say so, but the textbooks and journals do. Some preliminary brain imaging studies have shown inconsistent differences with children with the ADHD diagnosis, but there's no proof that they are deviations.
The diagnostic criteria for ADHD set forth in the DSM fail to define a disease. Further, it fails to distinguish normal behaviors from ADHD behaviors and ignores environmental factors such as those stemming from home, school, and community. Observing that textbooks and journals call it a disease, Carey establishes that the myth of ADHD is propagated by the leadership of psychiatric, pediatric, and medical academia.
Therefore, proof is needed that any test differences demonstrated with the ADHD diagnosis are signs of a disorder and not just of a temperamental predisposition. Furthermore, evidence of a genetic basis for the current diagnosis of ADHD cannot be taken as proof of brain abnormality because normal temperament variations and normal coping patterns also reveal substantial genetic contributions. The DSM-IV criteria for ADHD make no requirement to consider the environment in the etiology of the disorder. Since the problem is considered to be all in the child, the varying contributions of the setting are typically ignored.
While genetic factors have been shown to influence normal temperament differences, they have not been proven to have a causal role in ADHD. ADHD must be validated as a disease before one can logically consider its cause or causes.
The diagnostic questionnaires now in use are highly subjective and impressionistic. The current practice involves these brief, vaguely worded parent and teacher questionnaires to diagnose the presumed complex neurodevelopmental disability of ADHD. But the scales generally consist of only small numbers of items, are nebulously worded, often excessively, and so on, and place much of the responsibility not only for reporting the behavior, but also for making clinical judgments as to deviation in the eyes of the beholder. Variations in experience, tolerance, or criteria used among observers are not allowed for. They probably measure parent and teacher discomfort as much as they do the actual behavior of the child.
Here, Carey states, quote, "They probably measure parent and teacher discomfort as much as they do the pattern of behavior of the child," close quote. Thereafter, he adds, quote, "I believe they have not met adequate psychometric criteria," close quote.
Some observers maintain that the ADHD label represents real progress in the mental health diagnosis, in that it takes the blame off the parents in the schools, it helps children get services, and justifies the use of medication. But there are several negative aspects of this labeling. It is of limited practical value to teachers, psychologists, and physicians in that it offers no articulation of the child's problems and strengths and no suggestions for specific management other than medication. It may be misleading as to the true nature of the problem. The complex phenomenon of attention is analyzed in much too simple a way. The label may be harmful and stigmatizing by stating or implying that brain malfunction is present when it is unproven, and labels do stick.
They consider the child to have a disease when they do not. They label and treat the child and ignore the environment. I, for one, believe every such child is harmed. The next speaker is James Swanson, Ph.D., Professor of Pediatrics at the University of California, Irvine. Dr. Swanson presents a paper authored by himself and F. Xavier Castellanos, M.D., of the National Institute of Mental Health, entitled Biologic Bases of Attention Deficit Hyperactivity Disorder. Now to James Swanson, Ph.D.
I'll be talking today here about brain imaging with a small picture there of the caudate nucleus, which I'll be discussing, and molecular biology on the right, variations in the dopamine receptor genes. A good bit of the research that is going to be discussed today is at least partially inspired by the dopamine hypothesis of attention deficit disorder. This is something that has evolved over many years and is related to the use of medication. It is thought that the stimulant drugs have a site of action or sites of action in the dopamine pathways that are shown in this figure. And the very exquisite work of the group at Brookhaven, led by Dr. Nora Volkow, has helped us define this site of action. There's considerable work, which I will not be discussing today on the podium, about the pharmacokinetics of methylphenidate, which are being understood better every day and are telling us more about the brain basis of this disorder. But today what I will be talking about is the hypothesis that the dopamine pathways may be involved in attention deficit disorder.
Observe Swanson's talk of a brain basis of ADHD when no such thing has been proven. Further, he speaks of sites of action of Ritalin as though a diagnosis of ADHD could be based upon a patient's response to Ritalin, a flawed assumption disproven many years ago.
One of the first questions in this dopamine hypothesis is, are there smaller brain structures which have key roles in the control of movement? And we've looked at basal ganglia, caudate, globus pallidus, and the cerebellar vermis, the middle part right here, has been investigated by different teams. And I'll show you the results. Smaller basal ganglia were found in 4 studies. The 4 groups all found the same thing. You can see this is a combination of caudate nucleus and globus pallidus. About a 10% difference between ADHD and normal control subjects. The ADHD children in each study had smaller basal ganglia by about 10%. Effect sizes showing the difference between the ADHD and the control subjects divided by the standard deviation of the control subjects is shown on the right, and these are about 0.6 to 0.7 standard deviation unit differences. There's considerable variation in normal brains, so this is not something that can be used to diagnose the disorder at this point. But with groups, converging results have emerged that in this area there is a difference that has a neuroanatomical basis.
In their review of the brain scanning literature of ADHD, Swanson and Castellanos report that the brains of ADHD subjects are shrunken or atrophic and are, on average, 10% smaller than those of normal controls.
The third hypothesis from the dopamine, the third area that might be implicated by the dopamine hypothesis, the frontal lobes, where there are dopamine receptors. And there are three areas marked here derived from the work of Posner and Rakel, outlining three different areas of the frontal lobes for executive control, anterior cingulate gyrus, working memory, and alerting, right frontal area of the brain. Are these areas smaller? There are three of the groups have found very similar results. These areas, still gross definition of the frontal lobes, have been shown by three groups to be slightly smaller in ADHD children than in control children.
What they have neglected to say was that nearly all of the ADHD subjects in these studies had been on long-term amphetamine therapy, Ritalin most of all. In that ADHD has yet to be validated as a disease with a confirmatory abnormality to set ADHD subjects apart from normal controls, the chronic amphetamine status of the ADHD group looms as the only physical difference and the likely cause of their brain atrophy.
For over a decade, large-scale twin studies all have shown about the same thing, heritability of about 0.8. I don't think any study other than the first, which was reanalyzed with severity, and that figure was probably artificially low because it was the first study and the analysis was not restricted to the severe cases. However, these studies don't tell us what the molecular mechanisms are. And the dopamine hypothesis points us to a couple of candidate genes. Oftentimes this is kind of a hit or miss way of going about genetic work, but we've selected two candidate genes, the dopamine 4 gene and the dopamine transporter gene, here shown on chromosome 5 and chromosome 11. I will not talk about the other aspects of biological factors which I've covered in my paper to some extent, but not to the same extent as the genetics and the anatomy of attention deficit disorder, but fetal distress, traumatic brain injury, sleep problems, certainly other things of that nature contribute to the disorder that we're here discussing today.
Again, without validation of ADHD as a disease with a confirmatory abnormality for which to test, by which to identify it, there can be no logical talk of its cause or causes. I heard Dr. Swanson speak on ADHD at the March 7, 1998 American Society of Adolescent Psychiatry. Consider this exchange between Dr. Swanson and myself after that lecture.
I would like to have an objective diagnosis of this disorder. Right now, psychiatric diagnosis is completely subjective. So we'd like to have biological tests, and this has been sort of the dream for many years in psychiatry.
I salute your candor. There is no way of confirming ADHD as a disease in a medical sense. I am troubled that in this country we are giving dangerous, addictive drugs to between 4 and 5 million children who have no demonstrable disease.
That's why we're doing this work. I think we will validate it, and I don't think these drugs are dangerous and addictive when they're used this way.
Additionally, I wrote to Dr. Castellanos. In his reply to me of May 13, 1998, he made a startling confession. I agree that we have not yet met the burden of demonstrating the specific pathophysiology that we believe underlies this condition. However, my colleagues and I are certainly motivated by the belief that it will be possible in the near future to do so. This is myself in the audience questioning Dr. Swanson, now on a panel.
In those terms, ADHD is not yet qualified as a disease, despite which fact it is regularly and widely represented as a disease. The biggest single controversy, I think, about ADHD. Dr. Swanson, why did you not mention that virtually all of the ADHD subjects in the neuroimaging studies have been on chronic stimulant therapy, and that this is the likely cause of their brain atrophy?
Well, that's a hypothesis. I don't know the exact numbers of how many were or were not on medication, and as I indicated, I understand that as a critical issue. And in fact, I'm planning a study to investigate that. Haven't yet done it.
Here again is Dr. Carey, this time as a panel member, responding to a question from the audience.
Dr. Carey, and then we'll have to move on.
I'm uncomfortable with this concept of sub-threshold, which permeates the DSM. How can you have 5 criteria and be okay, and suddenly get one more and your brain turns out to be defective? I have a lot of trouble with that concept.
Yes,
why can't we call these kids normal?
Beginning on Wednesday morning, November 18th, panel chair David J. Kupfer presented the initial draft of the panel report for discussion and revision.
At this time, we do not have a diagnostic test for ADHD. Therefore, the validity of the disorder continues to be a problem.
Not a disease with a confirmatory abnormality, there is nothing to test for. And yet, they diagnose and drug 5 million children and spend billions on biological research for a cluster of behaviors never proven to have a biological basis or to be abnormal. With only a presumption of disease but no proof, such research is doomed to prove nothing. Its sole intention, it seems, is to weave illusions of biology and disease where none exist. This is Ben Leahy, Ph.D., Chief of Psychology, the University of Chicago.
Line 10 on page 3. At this time, we do not have a diagnostic test for ADHD, biochemical, physiological, anatomical, genetic, etc. Therefore, the validity of the disorder continues to be a problem. I agree that being able to correlate any psychiatric disorder with an anatomical abnormality or a biochemical abnormality would constitute a form of validity, but it's only one form of validity. And I think the thrust of the rest of your statement recognizes that the disorder has been substantially validated in other ways, which makes the sentence, which could be quoted out of context, therefore the validity of the disorder continues to be a problem, something that I think could be misunderstood.
If they were representing ADHD to be a cluster of problem behaviors in normal children, that would be one thing. But Leahy and all at the helm of the ADHD industry represent it to be a disease, an abnormality within the child, something in need of drug treatment. This is Keith Connors, director of the ADHD program at Duke University and author of the widely used Connors rating scales for the diagnosis of ADHD.
Keith Connors, Duke University. I had the same comments that Dr. Leahy did regarding the statement about the validity of the syndrome. I think that as worded, this will be taken out of context and suggesting that there is some validity. This is a disorder about which there is as much validity as any other medical disorder. And I am afraid that this is going to be used to suggest the continuing argument that after 100 years we really don't have a disorder.
Connors, like Leahy, is a leader of the ADHD industry. This is William Carey, professor of pediatrics of the University of Pennsylvania Medical School.
Page 3, line, what is that, 10, we see the statement that there is no diagnostic test for ADHD, and that theme continues throughout and appears in the final paragraph where it says that the causes of these behaviors called ADHD are entirely speculative. And yet out there in the real world across the land, parents and children are being told that these behaviors are due to a brain malfunction. Can you not please strengthen the statement to discourage practitioners from making this statement when there is not adequate proof to support that at this time?
We get proof that the ADHD industry, leaders of which dominate this conference, convey to public and practitioners alike that ADHD is a disease and abnormality in the brains of children, this in violation of the scientific record and of the requirements of informed consent. Here is a question from Craig Winslow, an attorney.
Yes, my name is Craig Winslow. I'm an attorney and the father of a wonderful son who has ADHD. And I was very generally pleased with the draft. There were two sentences that I had particular concerns about, and one is on page 5, where we say, in summary, there appears to be some level of validity in the diagnosis. That's such a weak statement. Lawyers and others use the word appears when they don't feel 100% comfortable with making a statement.
Until an abnormality has been demonstrated in the patient, the presence of disease has not been established. It must be a matter of objective evidence. With ADHD, it is not. Attorneys, judges, parents, and patients themselves are not diagnosticians, nor does the scientific physician delegate diagnosis. Here's a comment at this session from Richard de Grand Prix, author of the book Ritalin Nation.
My comment is on page 5. On line 7, it appears as you define disease as a maladaptive cluster of characteristics. I just want to point out that in the history of science and medicine, this would not be a valid definition of disease. Today, anorexia, bulimia, post-traumatic stress disorder, even in some people's eyes, being Jewish, homosexual, or homeless would define as disease according to that definition. So I think that if you use that definition to define disease, you end up including a lot of things that overlook the social, psychological, environmental factors that lead to them.
Even psychiatrist Donald Goodwin, author of the book Is Alcoholism Hereditary, acknowledges the narrow definition of disease that requires the presence of a biologic abnormality. Next, we hear from Planning Committee Chairman Peter Jensen of the National Institute of Mental Health, also a member of CHADD's Professional Advisory Board.
Peter Jensen, NIMH. Question 1, page 3, the infamous lines 10 and 11. I'd recommend, first of all, that there are clearly reliable measures and approaches to establishing the diagnosis. So we wouldn't want to mislead based on the evidence, which suggests there's clearly reliable diagnostic measures. The issue is that there's no independent diagnostic test apart from reliable diagnostic approaches. So beyond the independence of reliable diagnosis, we don't have another test.
Jensen, like Swanson, is a leading purveyor of ADHD as a disease. In 1996, with Ellen Schiller of the U.S. Department of Education, they wrote, quote, "Once parents and teachers recognize that children with ADD are not lazy or bad, but have a biological disorder, they can stop blaming themselves or their children and take appropriate steps to prevent a pattern of failure," close quote. Do we need to wonder any longer where the myth is coming from? The next comment is from Sheila Anderson, immediate past president of CHADD.
Sheila Anderson from CHADD. As a parent of 3 children with attention deficit disorder and a person who represents 35,000 families and professionals who either live with or treat attention deficit disorders, I have concern on page 3 with line 11. When you talk about the validity of this disorder, let me tell you that if you put this sentence out into the general public, considering the media that we have had to endure, if you think the disorder has an impact on our families, this statement that can and will be used out of context.
Here, the outgoing president of CHADD, believer in ADHD for her 3 children and the country, is saying they can't afford to publish the scientific facts of the matter, the lack of validity of ADHD as a disease. Anderson was also on the Consensus Conference Planning Committee and was one of 30 invited presenters at the conference. The next comment is from Candace Pert of Georgetown University, concerned mother, world-class neurochemist, and author of the book Molecules of Emotion.
I'm Candace Pert, Georgetown. I'm a mother and a neuroscience professional. And just one thing, Dr. Hyman in his opening comments made what I thought was a very important remark for this section while we're debating whether it's really a disease or not. The variation rate in diagnosis from 3% to 40%. I've traveled around the country a lot. I can tell you in Montgomery County, behavioral problems are referred to several psychiatrists. 100% of the children, I don't know what kind of diagnostic criteria are used, but 100% of them are recommended to go on Ritalin. In some places in Long Island, 50% of certain schools, the children are on Ritalin. We need to somehow address, probably maybe a little stronger in this section, the epidemiological issues that Dr. Hyman pointed to in his opening.
Without a scientific explanation, might there be a non-scientific explanation? Is ADHD an invention? Who invented it? Why? Clearly, ADHD is a multi-billion-dollar industry. How many make their livings at it? How many physician practices would go belly up were it not for ADHD? The next comment from the audience is from Red Howe, a young father from Chattanooga, Tennessee. His son, Corey, was one of 50% of his kindergarten class referred for a diagnosis of ADHD.
My name is Red Howe. I'm with Citizens Rescue and Youth. On page 3, line 2, the word disease. In the sentence, this indicates the need for better study of the disease in different populations and better definition of disorder. Disease and disorder are used, and there has never been a confirmatory marker showing a physical or chemical abnormality in ADD. Disease needs to be looked at, please.
Enough of 40 to 50% of children being said to have ADHD. Enough of 100% of those said to need Ritalin. Enough of claims that this is legitimate medical practice. This is Peter Breggin, MD, author of Talking Back to Ritalin and Toxic Psychiatry.
Question 2. In fact, there's a vast body of evidence showing that even
what line and page are you referring to?
The question was just by Dr. Connors, that there's a great deal of evidence that even daycare can affect the attention span of children, the hyperactivity of children, and that the number of daycare providers can do that the quality of a kindergarten can do it. So there's considerable evidence that the environment affects cognitive function, cognitive development, concentration, self-control, autonomy, and so on.
Okay, thank you.
The final event of the 3 days was the press conference chaired by Dr. David Kupfer.
Finally, after years of clinical research and experience with ADHD, our knowledge about the cause or causes of ADHD remains speculative. And indeed, we do not have any strategies with respect to the prevention of ADHD at this time.
Stressing the speculative nature of its cause or causes, Kupfer avoids the fact that ADHD doesn't exist, that the children are normal, and that all that has to be done to prevent ADHD is to confess that fact openly and publicly.
Jeff Levine with Medcast. Many say that psychostimulants like Ritalin are overprescribed. Some doctors say that these medications are underprescribed. Did you come to any sort of consensus or agreement as to whether or not, generally speaking, there's too much prescribing out there, or maybe the disease is generally undertreated?
I think the difficulty in answering the question is something that was already brought out, which is that there's no gold standard for the diagnosis, so that it's very difficult to look at a prescribing practice and say that this is appropriate or inappropriate unless you have a standard by which to judge the diagnosis of the disease. And that's why it's very difficult to answer the question head on.
Unless one knows who has it and who doesn't have it, one cannot possibly know if there is overtreatment or undertreatment.
John Roberts with the CBS Evening News. Did the panel take a look at the dramatic increase in the numbers of diagnoses of ADHD and come up with an idea of whether or not we're better at recognizing and diagnosing this, or if in some cases it's being used as a catch-all, a quick label for other childhood problems that may require a more aggressive intervention than just a pharmacological one?
Donna Ferrero, I think, as we stated in the statement, that we think there is an inconsistent manner in how this diagnosis is being made, which results in sometimes overdiagnosis and sometimes underdiagnosis.
Yes.
Joe Palca with National Public Radio. Could you explain a little bit more about how you can say, or how you do say, that the diagnosis is reliable, or it's a reliably diagnosable disease without any agreed upon tool or test or instrument for reaching that diagnosis? And second of all, just to go back a step, there's very little talk about what someone with this disorder appears like. I mean, could someone on the panel just say, this is what a child with this disorder behaves like, so that you would know when you think it might be an issue if it was someone like that in your family or in your neighborhood or in your school or whatever?
Bob? I'm going to answer half. I think we're using reliability in a very specific way here. And in reliability, it basically means that if a number of different experienced physicians using the same set of monitoring standards examine the same child, they'll agree in a large proportion of the cases. That's what we mean by reliability. And I think that one of the things that the panel has been discussing among ourselves is that that is different from the term validity, which I think is what you're talking about and is quite different outcome measure.
I think just to amplify on that part of the thing, we did hear, and the panel evaluated the number of diagnostic interview methods that are available, and those methods do appear to be reliable. However, what we're also concluding is at this point we do not have an independent diagnostic and valid test, such as a biological test or such as a blood test.
I still want to get to the other part of the question, which is just a description of what you might be looking for. Okay. But before you go on to that, it sounds a little bit like you're saying that the definition is a little like the Supreme Court's definition of pornography, which is you know it when you see it.
No,
I'm concerned.
We're going to disagree, and I would like any member of the panel to describe a typical ADHD in terms of symptomatology. Mark, would you like to? Since you see them in your practice.
I think the panel has been frank in, the difficulties here are immense in terms of these. It is hard. It's very hard to know how to answer this question. These kids In my experience, when you see these kids, they are, several standard deviations different in terms of they cannot sit still, they cannot attend, they cannot, even when they are as if driven by a motive. There are some good clinical descriptions of these kids. I think part of the problem is in the community. When you are a physician and somebody comes to you as a parent and says, my child might have attention deficit disorder, it's very difficult to know what to do. And how much confirmation do you need? Do you need a teacher who also who sees many kids and says, this kid is 2 standard deviations different from the other kids in my classroom? And the parent says this kid is different, and and then even if you say this child is different, you have immense problems with trying to say, why is this child different? Is this child being abused? Is this child lead poisoned? These kids do, if you spend time around children, and I'm not going to do a lot better than the Supreme Court here, these kids stick out like sore thumbs, and they are difficult, they aggravate their parents, but then it's further confounded by the fact there are subtypes of attention deficit disorder where kids have the problems with inattention without the hyperactivity. I think, I don't think the panel is saying anything different, although we said it in more sophisticated ways, is the diagnosis is a mess. But we all have a belief that we are dealing with a very serious core problem, and that we have a diagnosis that allows us to communicate and gives us research, generates sort of ideas for research. And I think, I think part of the problem is the profession keeps changing the diagnosis. We have DSM-4, the latest thing, but we have no guarantee that DSM-5 won't give us yet another diagnosis.
You have heard arguments, beliefs, lobbying, and a small amount of science, that from Professor Carey. What do you think? Are the children normal, or do they have a real brain disease? Are you aware that if your child is on such medication through 12 years of age, that he or she can no longer enlist in the armed forces? Do you understand that the drugs used to treat ADHD are addictive and dangerous, and that they can kill? Stephanie Hall of Canton, Ohio, on Ritalin for 5 years, died in her sleep for no other reason 5 days before her 12th birthday. Cameron Pettis, 14 years of age, of Austin, Texas, died an awful death from an allergic reaction to desipramine, a common antidepressant used as treatment for ADHD, a disease that doesn't exist. The $3.2 million award recently won for the family will not bring Cameron back. Telling you ADHD is a disease and that Ritalin is safe and non-addictive, they violate your informed consent rights, those born of the medical psychiatric crimes of Nazi Germany and of the Nuremberg trials. Is ADHD the epidemic of the century, or is it the healthcare fraud of the century? I testified to the Consensus Conference that without an iota of proof or credible science, the National Institute of Mental Health has proclaimed the behaviors of ADHD a disease, the children brain-diseased abnormal. CHAD, 35,000 strong, funded by Ciba-Geigy, manufacturer of Ritalin, spreads the neurobiological lie. The U.S. Department of Education, absolving itself of controlling the children and rendering them literate, coerces the labeling and drugging. ADHD has no clothes. It is not a matter of misdiagnosis or overdiagnosis. It is a total 100% fraud. With no proof with which to counter Carey's assertions, mine, or the scientific record, the final statement of the panel read, "We do not have an independent, valid test for ADHD, and there are no data to indicate that ADHD is due to brain malfunction. However, Their confession was buried deep within business-as-usual verbiage, and they never announced it forthrightly to the press or public. They could have put an end to ADHD, the disease and epidemic, but elected not to.
Dr. Fred Baumann, a practicing child neurologist for 35 years, has been a prolific author of child neurological articles. He has provided testimony at several national neurological conferences. He is licensed in the state of California and is a fellow of the American Academy of Neurology. He has held prominent positions on many child-centered causes.